Our brain bank is in Jacksonville, Florida, and it is based in this building at the Mayo Clinic. It's the Birdsall Medical Research Building. And so I was recruited in 1997 to the Mayo Clinic from Albert Einstein College of Medicine in New York to set up a brain bank. And that sign is totally wrong. The brains that we get from individuals that make a donation are invaluable. You can't even put a price tag on it. But just a little bit about brain banking that may or may not know the details here, but individuals make a decision, the family or often the individual themselves decide that they want to donate their brain for medical research. And through a process of working with either a medical examiner or a pathologist, tissue procurement organization, the brain is actually removed from the skull of the deceased individual. To be most valuable for research, that's done quickly after the time of passing, and part of the brain is preserved, and that preserved part is used for diagnostic studies, and the other part is frozen in as cold a freezer as possible so that can be used for research studies. But before anything can be done with the frozen part of the tissue for research, we need to know what the actual diagnosis was. And that involves a procedure that's illustrated here, what we call a brain cutting conference. And our brain cutting conference is actually a working conference, but it's also a teaching conference. The medical records are reviewed on the patients, the brain is evaluated, it's photographed, it's dissected. This is usually attended by medical residents, trainees, medical students, research trainees, and everybody gets to learn a little bit about that individual and gets to see what transpired in terms of the brain pathology. We've been doing this for over 20 years, and just in terms of MSA, brain banking, the brain bank was never set up to be specifically focused to collect MSA cases, but through the years, and actually prior to about 2008, we were getting about 4 cases per year, which it's not a large number of cases. But then in 2005, Cure PSP, one of the original supporters for our efforts in brain banking atypical Parkinsonian disorders, made a decision at an executive level, and I don't know how they made this decision, but they decided that it was important to actually support collection of MSA cases. And since then, we've been getting over 10 cases, sometimes more than 20 MSA brains per year. And we currently have over 270 brains of pathologically confirmed MSA. So what about the MSA that's actually, we know it's MSA with absolute certainty because we've evaluated the tissue. It's a disorder that affects men and women about equally. In our brain bank, and this reflects the nature of brain banking in the United States, and it's unfortunate that we don't have more involvement of minorities. So 95% of the individuals that decide to do brain donation are Caucasian. There are many reasons for this, and we really don't have time to discuss it, but there's a legacy of minorities being victims of misuse in terms of clinical studies, and so there's reluctance to participate in research. The average age at death is 66 years, but there's a wide age range. We have an MSA patient that passed away at age 37, and another one passed away at 91. The average disease duration is also quite variable, from as short as a year or two to as many as almost 20 years. If you look at the brains with MSA pathology, how many of them actually were thought to be MSA while that person was alive? More than 3/4, or about 3/4 of them actually were thought to have MSA. So the MSA pathology really drives a very distinctive clinical syndrome that is recognized by the overwhelming majority of clinicians. If you look at it the other way, of patients that while they were alive thought to have MSA, how many of them actually have MSA at autopsy? It's about 60%. So it means there are some other disorders that can masquerade as MSA, and they actually are PSP and Lewy body disease, or Lewy body Parkinson's. One thing that is interesting, if we think about most of the other neurodegenerative disorders, for example, Alzheimer's disease or Lewy body dementia, there's a significant proportion of patients that have a family history of other members of the family, the extended family, that might have had either dementia or Parkinsonism. But that's not the case for MSA. MSA does not seem to be a hereditary disorder. If there's a hereditary component, it's a very minor component. And so that really leaves us to the question of what besides bad luck determined why that person got the disease. And we don't really know. So where do we get the brains? They really come from almost every state in the Union. And because, and you'll hear a little bit later when we talk about the Brain Support Network, that where that group was based out of the Bay Area in California. California is actually the major source for brain donations to the brain bank in Florida. And then Florida obviously would be the next. So what happens after we do that brain dissection? So we take samples from very specific areas that we capture the most important areas that are affected by the disease, but we also take areas that are unaffected. The tissue samples that we sample are actually placed in paraffin wax. This is actually a section of the midbrain. And those paraffin sections are cut with very thin slices, about 5 microns thick, so it's thin enough that light actually passes through them. The tissue sections on the mounted slides are stained, and then the stained slides are provided to me to evaluate. We look at the tissue, the brain sections, under regular light microscopes, but also with fluorescent microscopy. We collect quantitative information about what we see under the microscope. That quantitative information and qualitative information is recorded in a written report, and that we generate a final diagnosis. It was MSA, it wasn't MSA. It was MSA with something else. It was MSA maybe with a stroke, MSA with some Alzheimer or aging pathology. That final diagnosis and the report is then entered into a database. It also is sent to the next of kin as well as to the pathologist that sent us the tissue. So, and then finally, the select cases are actually presented in clinical pathologic conferences. These are conferences where we present the whole picture. We do the clinical information, the imaging studies if they're available. We discuss the pathology. We show the gross, the images of the brain, the entire brain, the dissected brain, and then look at microscopic slides. And then through a process of learning and discussion, the clinicians, the students, the residents, we learn something about MSA. And so you may wonder what the 3 shields of the Mayo Clinic stand for. They stand for patient care, research, and education. And in fact, the brain donation contributes to all of those. Not so much patient care, but in terms of the diagnosis, actually more helpful to, obviously not helpful at all to the individual, but it's helpful to the family. So I think that kind of fits under the patient care shield. It's definitely valuable for research, and it's useful for education. One of the things that we can do with brain tissue is we can look at it with an electron microscope. This is a really high-powered microscope that uses electrons rather than light to evaluate the tissue. The electron beams pass through the tissue and basically hit a photographic film or a photosensitive plate that it then records the image. And it's through methods like this we're actually able to identify synuclein molecules in the individual cell. So the other thing that is done in terms of research is the frozen tissue is used for a variety of different types of research: molecular biology, biochemistry, and genetics. And to do that, small portion of the brain tissue are ground up or homogenized with a blender, and then various components of the tissue are extracted and used for research: proteins, lipids, nucleic acids, RNA, DNA. And that allows us to actually look at the chemical changes that occur in synuclein in the brain. And the DNA that is extracted can be used for a variety of genetic studies, both that are done at Mayo Clinic, but also we participate in a number of national and international studies on genetics of MSA. So just what does the brain look like in a typical MSA? This is an MSA-P, a patient with striatonigral degeneration. And what it illustrates is that the two characteristic features are degeneration of the striatum, and that the striatum includes the caudate nucleus and the putamen, and the arrow on the right is pointing to the putamen. That putamen is about a quarter of the size that it should be because the neurons have been lost. And also, if you notice that it has the color is different. It's a little bit browner than the rest of the brain around it. That brown color actually is because there's excessive accumulation of iron. And I think earlier this morning we talked about how imaging methods can actually detect iron and monitor their increased iron. And the arrow on the left is then pointing to the substantia nigra. That should have black pigment, and it doesn't look black at all. It looks kind of tan or light brown. That's reflecting the severe neuronal loss in the nigra. So those are the two areas, nigrostriatal degeneration. Many patients with MSA, that's the major pathology. There's very little other pathology that you can see with the naked eye. The other form is Olivopontocerebellar degeneration. And in this form, the degeneration affects different parts of the brain. It affects the brainstem, especially the pons and the medulla, and it affects the cerebellum. And I try to do this without advancing it. Maybe if the pointer will work, I can try to. Yes, okay. So this is the cerebrum. I think actually Nick actually showed you an MR of a brain that was cut almost in this same plane. We're looking right, as if you split the brain right in half into right and halves of the brain. And this is the midbrain. This is where those substantia nigra dopaminergic neurons are. It looks pretty normal, but the pons should be 2 to 3 times the size of this. It's markedly atrophied in MSA. And then, so this is the pons. The midbrain the pons usually twice as large as the midbrain, and it's just the reverse. The midbrain's almost as large. So very severe pontocerebellar atrophy. And the pathways that project into the pons or into the cerebellum also undergo atrophy. So this is a normal projection fiber from the pons into the cerebellum, and then here's the MSA in comparison. So very discrete pathology. The thing that links these two disorders together, even though they look very different, and clinically they're very different, is the fact that they have the same molecular pathology, and that's the abnormal alpha-synuclein. So in terms of the brain bank, patients are classified as either this pure OPCA or the pure striatonigral, and then there's a group of patients who have the full house. They have both. They're really unfortunate. Are there any characteristics that distinguish the striatonigral from the OPCA, the MSA-P and the MSA-C? There are not a lot of differences. One of the things that comes up is OPCA is more common in men, and I think Nick also presented this from larger clinical studies, and that for reasons that are unclear, the MSA cerebellar form is more common in men than women. And the other thing that seems to be recurrent, even though we don't have a lot of non-Caucasians, the non-Caucasians are overrepresented in the MSA-C. And in fact, in Asia, there's a really nice study from a Japanese investigator working in the Queen Square Brain Bank who also evaluated MSA patients in Japan. And MSA-C is much more common in Japan, whereas in the Queen Square Brain Bank in England, it's MSA-P. So striatonigral degeneration in European Caucasians, and in Asians, it's more C. We don't know. That might suggest genetic underpinnings, but we don't have really good evidence of that. So the major pathology that unites the MSA-P and MSA-C is the alpha-synuclein pathology. Alpha-synuclein was discovered as the gene that caused familial Parkinson's. It was actually discovered in 1997, and a number of groups shortly after that said, well, let's look at our brain bank and see what else besides Parkinson's might have alpha-synuclein. We actually did this. We were one of the first to actually report in 1999, teaming up with Sid Gilman and his team at the University of Michigan. We didn't have very many MSA cases at the time, and Sid and Roger Albin, they sent us MSA cases from the University of Michigan so we could confirm this finding in a larger cohort. And in fact, both the glial inclusions and the neuronal inclusions were described. And using markers that were specific for oligodendroglia, we could show that in fact the inclusions, the synuclein inclusions were in oligodendroglial cells. In that same study, we actually looked at changes in the solubility. The synuclein that deposits, synuclein is not normally a lump in a cell. It's a soluble protein, has dynamic properties. It's very important for the normal synaptic function of neurons. What it's doing in oligos is another question, and we really don't have a clue. But it's present in both. And that fact that it aggregates, it tells us something's abnormal with that protein because it actually changes in its solubility. And looking at more stringent solubility, going from very soluble to S5, there's really insoluble, like it's material that actually precipitates. And you'll see that in MSA, it's very different from what you see in normal controls and Alzheimer's. The other thing, using our electron microscope, we're actually able to look at individual cells that have those synuclein aggregates and show that the synuclein, which normally you can't see in a cell, it's just diffused throughout the cytoplasm of the cell. In MSA, it actually accumulates into actual filamentous or structures that you can actually visualize. Now, I mentioned that we've submitted a number of our MSA samples to a number of genetic studies, and both conducted at Mayo Clinic by our geneticists led by Matt Farrer and Owen Ross, and also to international studies that especially work done by Sonia Schultz at the NIH with Andy Singleton also at the NIH. And the bottom line from all these studies, negative. They're all negative studies. All the genetic studies have been done on MSA are essentially negative. And that fits with why we don't see a family history of MSA. This is probably not a disorder that is strongly driven by genetics. We need to go outside of genetics and think outside the box in terms of what actually causes this. And we need a lot more work on that in that area. One of the things that has been that we've used our brain bank for is to do clinicopathologic studies where we can review the medical records of the patients, look at the pathology, and try to understand why did this patient have pathology of MSA, but when they were alive, they were thought to have Parkinson's disease or thought to have progressive supranuclear palsy. And these are studies that have been led by a number of research fellows. I would just point out that, did I advance? Okay, it didn't advance. Okay, these are not quite the latest slides. I just had another version of this that actually pointed out that Shunsky Koga has actually spearheaded a lot of our clinical pathologic studies. And this paper in neurology is an important study because it says that sometimes patients that are clinically thought to have MSA don't have MSA. They might have Parkinson's disease or Lewy body dementia. And the most common reason that Parkinson patients or Lewy body dementia patients are thought to have MSA is because they have autonomic dysfunction. So a Parkinson patient with autonomic dysfunction can get misdiagnosed as MSA. And PSP patients can get diagnosed as MSA if they have cerebellar involvement. So PSP is an atypical Parkinsonian disorder that usually leads to early falls, axial rigidity, and impairment of vertical eye movements. But some of these patients have more cerebellar involvement, so they have a clumsiness or ataxia. Those patients with Parkinsonism and that ataxia, that leads them to get misdiagnosed as MSA. So how to do a brain donation? If you make that important decision, it's a difficult decision. It has to be something that you discuss amongst yourselves, your family, friends, maybe people that have gone through this, families that have gone through this process. There are some ways to reach out. You can find information at the Mayo Clinic. The Multiple System Atrophy Coalition actually has a link to information about brain donation. And the MSA Coalition has teamed up with the Brain Support Network. This is, I mentioned, is a not-for-profit organization that grew out of a family support group in the Bay Area in San Francisco. And now they've been assisting families in making brain donations, and now they've, led by Robin Riddle, they've actually got a really efficient team. a very good database of pathologists and pathologist assistants and medical examiners, tissue procurement organizations throughout the entire country that can help families, if they make the decision they want to have a brain donation, how do they actually go about doing that? The other place where you can find information about the brain donation is PSP. I mentioned PSP. PSP is a tauopathy. It really has, it's very different from MSA. Some patients get misdiagnosed. But I credit our boost in terms of our brain banking for MSA on Cure PSP because they actually went out of their way to say that we should be actually engaging the MSA as well in terms of offering brain banking for this also rare atypical Parkinsonian disorder. And then finally, just point out some of the people in the lab, past and present, that have contributed to the studies, the research study, and I highlight Dr. Koga because it's been a major focus of his research on clinicopathologic and genetic studies on MSA. And I'll take some questions if we have time. Are we doing it, Rob? Okay.
Thank you, Dr. Dickson, for that very informative talk.